Hello, this is Dr. Thomas Kislan from Eyecare Today. We recently filmed a seminar on macular degeneration and the newest treatment for macular degeneration called Photobiomodulation with the Valeda instrument. Please enjoy these highlights from the seminar. We're going to talk about macular degeneration and some new technology that is, we're the first in Pennsylvania to offer this, so it's really exciting. We have 5 locations, and we always strive to bring new technology to the area. Whenever there's some new gadget, some new toy, something that's going to benefit patient care, we always try to be on the forefront of bringing that to the area. So we have 5 locations. Hazleton is kind of our main location. That's on the airport beltway. These are all of our docs that practice there. We have an office in Stroudsburg also. I practice in the Stroudsburg office 1.5 days a week, but mostly I'm in Hazleton. We have an office in Bangor and Dr. Bellinger, and we have a new doctor, Dr. Thomas, who practices there. And we have a Nanticoke office, Dr. Wylam. She practices in Nanticoke, and then we have an office in Pottsville also. So we have 5 locations kind of spread out through the area, providing care to a lot of folks. Let's talk about what macular degeneration is. So there's 2 types of macular degeneration. There's what's called the dry form and what's called the wet form. So the dry form is the most common. Probably 80 to 85% of all macular degeneration is the dry form, and the rest is the wet form. So that's the least common form. The dry form is usually a slower progressing condition. It could take years to change or affect our vision. The wet form is usually much quicker. I'll have patients, they'll call the office and say, I woke up and I can't see out of my right eye, can I come in? And they come in and they have a large bleed in the back of the eye. The wet means that there's bleeding in the back of the eye. So it can be really fast and can take our vision really suddenly. We can go from being able to see pretty good on the eye chart to not even being able to see the big E. So our goal is to help prevent patients getting to the wet. That's been our goal all along. And it's been tough because really when we look at the dry form, up until now there's really been nothing much to do except tell you to take certain vitamins, which we'll talk about, protect your eyes from the sun, don't smoke, have a decent diet, exercise, stay in good shape, and that's really all we had. And we'd have patients come in and they have dry and we'll say, how you doing? Okay, well you didn't turn the wet, yay, that's great, and I'll see you in 4 months. There really was nothing else to offer our patients. So until now, which is what we're going to talk about. The wet macular degeneration, the treatment that we have is injections. So for those of you that have wet and are getting injections, you know, it's not the most fun thing in the world. It's every 6 to 8 weeks for the rest of your life. You're getting a needle in the eye. And the goal of the injections, and I get this question all the time, is to prevent progression and kind of keep you where you're at. Unfortunately, in most cases, the injections don't make us better. Whatever vision we've lost at that point, we usually don't get back. This is a normal eye. And what happens in early dry macular degeneration is we start to get these drusen. So drusen are waste products of those cells. Those waste products deposit in the back of the eye. Our eyes just can't get rid of them, so they deposit there. And these are called drusen. Drusen are made of lipids, proteins, and a lot of other stuff, but they're these round yellow deposits that sit in the retina and sometimes around the macula. But where we worry is when those drusen start to sit right in the macula. And this is what it looks like when that happens. So we're going to see blurry, we may see distorted, we're just not going to see well. And the more drusen we have there, the worse our vision is. So in early AMD, we've got these tiny little drusen. In intermediate, these drusen get bigger, they start to infiltrate the macula. And then we end up with more advanced dry macular degeneration, which is called geographic atrophy. And this is where this tissue, just because nutrients can't get back there either, the tissue just breaks down and it just goes away. So what are some of the symptoms? Well, blurry, fuzzy central vision.
problems reading, needing more light to see, contrast issues. Now, what's confusing about that is there's lots of things in eye care that can cause that. So cataracts, dry eye, a lot of other stuff. So the key is making sure that you're seeing a doc who, can determine whether or not you have cataracts or you have macular degeneration. So, we may get some distortion in the early stages in our images, some blurriness, but then when we start getting into the darkening in the central visual field, that's where really it's advanced. And once we get to this point, we can't get it back. So again, our goal is to prevent that. What are some things that can make this worse? Well, age is one. So age-related macular degeneration is the name of the disease. So as we get older, we're more at risk for it. It's probably 80% Caucasian, and it's usually about 3 to 1 women to men. Age 60 to 70 increases your risk by 5 to 6 times. Family history is a huge risk factor. Smoking is a huge risk factor. Smoking increases your risk of progression by almost 11 times. Cardiovascular health, so making sure your blood pressure, cholesterol, sugar is all under control, which leads to diet and sun exposure. So how do we diagnose it? In the eye exam, obviously we're going to check patient's vision. We're going to do that OCT scan that I talked about. We do something called an ERG also. We put these little electrodes on the head, and then you look in this machine, and it takes about 1.5 minutes. And basically what it does, it tells us how fast the signal is going from the eye to the brain and back. So think of it as high-speed internet versus dial-up. The faster that signal goes from the eye to the brain and back, the better our vision's going to be. In certain diseases, macular degeneration being one, but glaucoma another, diabetes, that signal is slowed down in those diseases. So we want to make sure that signal is going nice and fast. If we see a slowing of that signal, that's telling us something's wrong. And sometimes we'll see a slowing of that signal before the drusen actually show up. So that's a red flag. So we're actually pretty proud. We're the first ones in the area to have ERGs as a tool to help diagnose our patients. So now we're at this technology, which has been used in Europe since 2019, but it's finally in the United States in November, and the device was made available in around January-ish, and there were none in Pennsylvania until us. So we're talking about here something called photobiomodulation, which is a big word for red light therapy. Okay, it's not laser, it's light therapy. There's a difference. It has to do with the wavelength of the light, and the name of the machine is Valeda. So it's the only FDA authorized treatment for dry macular degeneration that carries the labeling that improves vision. So remember I said we have nothing up until this point that actually can improve vision. We finally do. So it improves vision, slows progression, and actually improves the health of that retinal tissue. So red light therapy has been around a while, and it's been used in medicine, but this is the first time that they've actually found something that can actually work inside the eye. We use it around the eye for dry eye, but for actually in the eye, this is really the first thing. So November 2024, FDA authorized. So like I said, first and only FDA authorized treatment. The name of the study was the LightSight 3 study. It was a 24-month trial that looked at visual acuity. It's been in Europe and available in other countries, including Latin America. It's non-invasive, very safe, no signs of any phototoxicity or really any side effects at all. The treatment is extremely straightforward. There's no pupil dilation required. There's no needles. There's no drops. There's no nothing. The treatments are a series of 9 treatments. So what it is, you have to do 3 treatments a week, 3 weeks out of 5. So we usually do a week, skip a week, do a week, skip a week, do a week. So that's 9 treatments, and that has to be done 3 times a year for 2 years. That's the protocol that's used in Europe, and that's the protocol that was used in the FDA trial in the United States. In our cells is something called the mitochondria. The mitochondria is like the heart of the cell. It's the powerhouse of the cell. It's kind of what drives everything in that cell to keep going. If we lose the mitochondria, we lose the cell. So what red light does is it stimulates something called cytochrome C oxidase, which basically makes the mitochondria work harder and flick that switch and give the cells its energy that it needs to keep going. Remember I said if those cells stop working, you have drusen that build up and those cells just they die? Well, this helps prevent that. Red light just helps those mitochondria just keep going and going and going. So again, this is kind of what it looks like. It's a very easy, simple, you put your head in, are we doing one eye or two eyes? Pretty straightforward. We line everything up, and that's all there is to it. The treatments are 4 minutes and 15 seconds an eye. So you're basically in the office maybe 15, 20 minutes. That's the amount of time that you're in the office. So you're not there that long. And this is what we saw as far as visual acuity. So on the bottom here is our vision with the sham group, so the patients who did not get the actual therapy. And this is the patients that got the therapy. And this dotted line here is one line of vision better on the acuity chart. So you all go into the eye doctor, you read the chart, and there's usually a couple different lines there. So let's say you're 20/40, this got you to at least 20/30. If you were 20/60, which, 20/60, 20/70, you can't drive. Now we get you to 20/50, 20/40, now you can drive. So that's kind of what we were seeing in the clinical trial as far as visual improvement. And this kind of looks at it from month 13 to month 21 to month 24. This is 5 letters or more, which is one line. So the majority of patients got this one line, but there were these outliers here that actually got up to 15 letters of improvement, which is 3 lines on the acuity chart. So now we're taking someone who's 20/60 and making them 20/30. That's huge. Now, it's not a huge percent of patients, but we call them super responders. They responded extremely well to the treatment. What happened in the patients who didn't get the treatment? Well, again, the gray is the sham or the placebo. This is the patients that got treatment. The patients who didn't get the treatment, who got the fake light, they got worse over 24 months. They definitely progressed. So macular degeneration is a progressive disease. We just said that. So in 2 years, these patients lost over a line of vision. So that's a lot in 2 years. In studies like this, they usually talk about quality of life. And again, like I said before, most patients say, I'd rather anything else happen to me except lose my vision. And these patients kind of said the same thing. And then they asked them, the patients in the sham group, what are you having most trouble with? The patients who were treated really were doing great with everything in life, but the patients in the sham group were having trouble with daily activities, near vision, difficulty reading the newspaper. So again, those patients' quality of life got worse. This was the thing that really just, when I saw this part, I'm like, we got to get this. I was on a call talking to one of the VPs of the company going over the data, and Dr. Diem was on the call also, and I was here, he was out of town, and I think at the same time we both went, holy crap, when we saw this. So those drusen that I showed you pictures of before, that I said are kind of the culprits of all this getting worse, the way this helps you is it actually makes those drusen go away. It actually helps to shrink those drusen and make those drusen smaller. So when they looked at drusen volume, so how big were those drusen to start and how big were they when we finished after 24 months, we saw almost a 2-time improvement in drusen size. So again, the placebo or sham group is here, and the patients after 24 months that got the actual treatment, those drusen were basically cut in half. They were made 50% smaller. So that's a huge deal. If we can reduce those drusen, we're going to reduce the risk of this condition progressing and patients losing vision. So on the left here is the patient at the start of the study. So again, here's that OCT scan that we do every visit when the patients come in, and these bumps, they look like speed bumps, right? Those speed bumps are the drusen. So after 21 months of treatment, that's what the retina looked like. Huge, huge improvement. This is just another way to look at it. This was a patient, right eye, left eye. So in one eye, they got the placebo or the sham, and in the other eye, they actually got the treatment. And this is just a different way that we look at these scans, but the white here is the drusen volume, and which means the amount of drusen in that area, And you can see over the time period of the study, it really progressed. The patients that got the photobiomodulation really didn't do much at all. That geographic atrophy. What about patients in the study who had geographic atrophy? So that's the dry macular degeneration that there's now a shot for. Patients in the sham group progressively got worse. Patients in the photobiomodulation group really did not. Huge difference in the placebo versus the treated group. So again, if you are already at that point where you have geographic atrophy, there's something we can do to really slow it down and again, hopefully get some improvement. And again, vision-wise, the treated patients stayed the same, which is good, but the sham or placebo group got worse. So geographic atrophy in this study in 24 months definitely progressed, which we would kind of guess that was going to happen. Anything bad happen? I have nothing up there. There's really no adverse events at all from the treatment. The biggest thing patients will say, it's kind of like if you get your picture taken and the flash goes off for a couple seconds when you're done, you kind of have that little, you got to blink a little bit and kind of let your vision come back. That's all that happens. You can drive afterwards. You don't need a driver, anything like that. In the clinical trial, nothing happened unexpectedly. There was no infection, there was nothing bad, there was really nothing that was statistically significant that wouldn't have happened in real life. When we compare Valeda or photobiomodulation to the injections that are out there right now for geographic atrophy, so Syfovre and Izervay are the two injections for the advanced dry macular degeneration, what is the chance that those patients are going to progress, even getting the injections, right? So even getting those shots in the eye, are you going to progress? And depending on the study, we're at 11%, 8%, almost 12% here, and in photobiomodulation, because again, we can't guarantee that everyone's going to stay good forever. It's a progressive disease. Some patients, genetics, whatever, they may get worse. But 2.9% progression in the one study, 4.2, 7%. So there is still a risk that the condition could get worse. But again, if we catch it early and don't get to this point, that's all the better. And I just put these slides up here because there's a ton of clinical data out there. These are studies, Canada, USA, France, Germany, United Kingdom, Italy, ongoing studies now in the US, the Netherlands. There's all these studies out there still going on about photobiomodulation and the benefits. In photobiomodulation in general, there's over 10,000 published articles, 200 articles in ophthalmology. So this is not something really new. It's been studied a lot. There's a lot of data out there to support what we're seeing. These are just some more diagrams and some pictures. These are 3 different patients. So start to finish, you can see again, here's those drusen. And then at the end of treatment, you can see the improvement. I mean, this patient's almost perfect. This is FDA approved for macular degeneration. There are conditions that are outside of that. That it can be used off-label for. This is a condition called central serous retinopathy, where it just means there's fluid in the back of the eye, and sometimes there's no reason. We don't know why, but it just happens. The patient has swelling in the back of the eye. Usually it's younger white males we see this in, but this is treatment just after 3 weeks of treatment. So this was a short course of treatment. It got better. This is probably the area we're going to see more and more studies and data and use for this going forward. It's our diabetic patients. What we call diabetic macular edema. So if a patient's blood sugar, if they have issues and they have problems in the back of the eye, one of the worst things we can see is swelling in the back of the eye called macular edema. There's studies ongoing to help this, and this just shows a patient kind of before. So this is all fluid in their retina here, in their macula, and this is after. There's a definite reduction. So again, the treatment schedule, if patients come, it's 9 treatments over kind of 4 to 5 weeks, and they only last, you're in the office 10 to 15 minutes. And you have to do those treatments 3 times a year for 2 years. That's kind of the treatment protocol. Non-invasive and painless, no needles, no surgery. It's in office. You're in the office only a couple minutes, you sit comfortably, there's no downtime, you can go to back to work, go to any of your activities. So this is usually the question I get, what does it cost? So unfortunately, it's not covered by insurance. Usually when new technology comes out, it takes a while for Medicare and other insurers to maybe catch on. In Europe, it's still not covered by insurance over in Europe, so we're just not sure what's going to happen. But the cost for the treatments are $175 for each individual treatment. So if you add that up for a year, you're looking at $47.25 for the year. If patients pay the whole thing up front, it's $4,500, they get a little bit of a break. If they pay 2 years up front, it's $8,500, they get about $1,000 off. There's ways that we can make that a little bit more affordable. There's things called care credit and cherry, some other things. The key to determining whether you're a candidate is to just come in and see us. And we will check your vision, we do a retinal scan, we'll do an OCT, we'll do an ERG, see kind of where you're at, see what level of macular degeneration you have, and whether or not you're a candidate. That's kind of the key, is determining whether or not this is something that could be beneficial or not. If it's not beneficial, we're going to tell you it's not going to be beneficial because we want it to help. We want patients to do well with it. It is not approved for wet, okay? But I have a couple patients that have said to me, I'm done with the injections, I don't want to do them anymore. I get an infection or I get an abrasion or whatever after every injection, they're just done, and they want to do the treatment. It will not hurt anything. If you put 10 retina specialists in this room, 5 will tell you that you could do it with wet, 5 will say you should not because it hasn't been studied. So we do things in medicine all the time that are off-label. Because it's not an insurance thing, we don't really have to worry about what an insurance company tells us to do or not do. That is a very personal one-on-one decision that I would make with you, whether or not we treat that eye or not. In our offices, we have 3 retina specialists. We have one in the Hazleton office, we have one that covers 2 of our other locations, and we have one out in our Tannersville office. 2 of them say treat the wet, and one says don't treat the wet. So again, it's all over the place, and as we learn more, we'll know more. When this first came out, when I first decided we were going to do this, I made 2 calls. One was to the retina specialist in Louisiana, who was the first one in the country to actually perform a treatment post FDA approval, and I talked to him about it, and he said, oh yeah, I'm treating my wet patients too. He's like, I'm doing dry and wet. Then the second call I made was I just Googled someone in Europe. I said, who in Europe is doing this? And I found the name of a doctor in England, and I called, they answered, and they got the doctor on the phone, and I had like a 20-minute conversation with her. And she's like, yeah, I've been doing this since 2019. She said, it's unbelievable. She says, we're doing it on wet, dry, diabetics. I mean, it's, you know, they're 6 years ahead of us as far as this goes. So, you know, FDA authorization means one thing, but every patient's different. My oldest patient doing this is 94. And she walks 1.5 miles a day. So God bless her. So after 2 years, can this stuff come back? What we know, for at least 20 months post-treatment, patients stayed pretty good. They didn't progressively get worse. Now after that, we just don't know yet. They'll probably work on another extension trial, but that was just, it's not even published yet. I just got it in my email and he said, don't tell anybody. So I just told 50 people. So it looks like the benefits stay for at least 2 years. So I thank everybody for coming. I hope you learned something. You're more than welcome to make an appointment. If you'd like to come in and talk to us, you can come in, make an appointment. We'll do your scans. We'll take a look, see what the back of the eye looks like, and talk about your options. Again, thank you for your time, and have a great summer.